Hello people, in this video we want to look at Marcus Gunn pupil. So basically in abnormal pupillary reactions, Marcus Gunn pupil is one of them. If there is Marcus Gunn pupil, it indicates that the person has some relative afferent pupillary defect. Okay. So basically what are they trying to tell here? It's an abnormal pupillary reaction. Normally if light falls on the eye, what will happen? The pupil should constrict. So here you can see that when light is falling on this eye, the pupil is constricting, and the both sides are constricting. But in Marcus Gunn pupil, kind of what happens is, when you put light on this eye, which is having issue, it is not constricting. Okay, so here you can see there is no constriction, right? So this is Marcus Gunn pupil. So why is this so important? This is indicating afferent defect. What is it indicating? Afferent defect. So it is indicating relative afferent pupillary defect. So it is going to be the earliest indication of optic nerve disease. Means what? So let us see the afferent pathway. Okay. So look at this. Whenever light falls on, whenever light falls on this eye, so the information is going to go to the brain. How? From the retina to optic nerve to optic chiasma, optic tract, right? From there it will go to two places, pretectal nucleus, and then you have the lateral geniculate body. So we are concerned here with the pathway which is about the pupillary reflex. So you have the retina, optic nerve, optic chiasma, optic tract, pretectal nucleus. From here it goes to Edinger-Westphal nucleus. Now it is coming back. Edinger-Westphal nucleus. From there the information comes back saying that please constrict pupil. Light has fallen. So Edinger-Westphal nucleus, third cranial nerve, ciliary ganglion, short ciliary nerve, sphincter pupillae. And it got the information, please constrict the pupil. So how did the afferent and efferent come? You saw how the afferent came. How did the afferent come, guys? The afferent came retina, optic nerve, optic chiasma, optic tract. From there pretectal nucleus. Now coming backwards, information is being sent back to the eye. Edinger-Westphal nucleus, ciliary ganglion via the third cranial nerve, short ciliary nerve, sphincter pupillae, please constrict the eye. Light has fallen, right? This is the information. What will happen, guys, if there is a lesion in the optic nerve? Okay, so where is the lesion? Let us say there is a lesion in the retina or in the optic nerve or something, okay? So what will happen? This pupil will not constrict. So when the pupil doesn't constrict, it will indicate to you what? It will indicate to you that there is afferent defect. So a Marcus Gunn pupil can be an early indicator of an optic nerve disease or a retinal damage. Okay. So as this pretectal nucleus is supplying information to both sides. See, pretectal nucleus is supplying information to the other side, Edinger-Westphal also. So both the pupils were supposed to constrict. Now because there is an afferent defect here on this side, both the pupils will not constrict. Okay. Did you understand, guys? Because the afferent pathway has a defect, right? Whenever you put light on this eye, because the afferent pathway has a defect, this pupil will not constrict, and even the other side pupil will not constrict. Okay, this is Marcus Gunn pupil. So Marcus Gunn pupil indicates RAPD. It indicates relative afferent pupillary defect. Afferent is towards the brain, so sensory information. Okay, so basically it is an abnormal pupillary reaction. It is an early indication of optic nerve disease and also of retinal damage, right? So we saw the pupillary pathway, afferent and efferent both we saw. So basically Marcus Gunn pupil is a paradoxical response of the pupil to light in the presence of this relative afferent pupillary defect. So here there can be optic nerve lesion or retinal disease. How will you test it? By swinging flashlight test. So basically they are going to swing the light from one eye to the other. It is a relative check, okay? Pay attention here, guys. The lesion, if it is on one side, then only you can make out, okay? It's a relative condition. You'll compare it with the other eye, okay? So unilateral optic nerve lesion with good vision. Even vision should be good. That means there is a lesion, but the vision is still good. So it's an early indication kind of a thing. Guys, look at this severe RAPD and see if you can understand. Swinging flashlight, constricting pupil, constricting pupil, but it's little slow. Constricting pupil, it's dilating. Constricting pupil, dilating. Constricting pupil, dilating. So guys, did you understand? In the presence of relative afferent pupil pathway defect, one eye, the affected pupil will dilate. The affected pupil will dilate when the flashlight is moved from the normal eye to the abnormal eye. Okay, this is important. What did you understand, guys? It is an early indication of optic nerve disease. So it is important. Okay. So what are the causes of Marcus Gunn pupil? Very easily you will say 3 things with retina you tell, okay? And 3 things with the optic nerve you say. For retina you say retinal detachment, retinal artery occlusion, retinal vein occlusion, central retinal artery occlusion, central retinal vein occlusion, retinal detachment. We told you, right? It is afferent. So retinal disease or even optic nerve disease. So with respect to retina, we said retinal detachment, retinal vein occlusion, artery occlusion, central retinal vein occlusion, central retinal artery occlusion. When it comes to optic nerve, they are saying optic neuritis, optic nerve atrophy, traumatic optic neuropathy. So you had a trauma or something, so you could have damaged the optic nerve. So early indication could be a Marcus Gunn pupil. So optic neuritis is inflammation and demyelinating disorder of optic nerve. Optic nerve atrophy means degeneration of the optic nerve, traumatic optic neuropathy. Okay. So what is this optic neuritis? Here you will see inflammation, demyelinating disorder of optic nerve. Again here what will you see? The pupil shows ill sustained constriction to light. So it is not constricting very well. Okay. So it is a diagnostic sign. Marcus Gunn pupil will be a diagnostic sign of optic neuritis. How will you detect it? Swinging flashlight test. In proptosis, if there is Marcus Gunn pupil, it can suggest that the optic nerve has got compressed. Okay, another optic nerve condition. Then, if you are carrying out a cataract surgery, right, how will you know that the retina is fine? Because you will do cataract surgery and then the patient still can't see because the retina was not fine. So you have to check the retina. Without, you cannot do fundus examination because the lens is opaque. So one of the retinal function tests that you can do before carrying out a cataract surgery can be a Marcus Gunn pupil response. That is why even this test is very useful. Not that it is not just that it is an early indication of optic nerve disease or retinal disease. It can also help you test retina before a cataract surgery. Okay. So the other tests for retina in a person with cataract, because you cannot check the fundus, etc. Light perception, projection of light rays, and 2 light discrimination test and Marcus Gunn pupillary response. Did it make sense, guys? You're checking the retina. Okay. Before cataract surgery, you want to check retina. How can you check? Here with Marcus Gunn pupillary response. Okay. So don't get confused with Marcus Gunn jaw winking ptosis, guys. That's a different condition that is also having the same name, Marcus Gunn. So basically in this video you saw Marcus Gunn pupil. Okay, so if there is Marcus Gunn pupil, which is an abnormal pupillary reaction, it indicates RAPD. It is relative afferent pupillary defect. It is the earliest indication of optic nerve disease because we are checking the afferent pathway. So basically it is an early indication of optic nerve disease or even retinal disease. So this is your pathway. So here they are showing you the afferent pathway and this is the efferent pathway, right? Afferent and efferent. So if there is lesion in the afferent pathway, there will be no constriction of the pupil on both sides. There will be no constriction of pupil. So that is what will indicate an early optic nerve disease. Okay. So how will you do this? By swinging flashlight test, which you saw now, swinging flashlight test. So this is a relative check. So unilateral optic nerve lesion only, if it is there, you can check. Okay. So what will happen? The affected pupil will dilate when the flashlight is moved from the normal eye to the abnormal eye. The affected pupil will dilate. Important. What are the causes? Retinal detachment, central retinal artery occlusion, central retinal vein occlusion, optic neuritis, optic nerve atrophy, traumatic optic neuropathy. So what else? In proptosis, it can happen that even the optic nerve is compressed, so there can be Marcus Gunn pupil. So when you can, when you want to check the retina, one of the checks is Marcus Gunn pupil, especially in cataractus lens, because you cannot see the fundus. Don't confuse with Marcus Gunn winking ptosis. That's a different condition. So basically in this, remember Marcus Gunn pupil, abnormal pupillary reaction. Just note here one thing, guys, that from the optic tract, okay, from the optic tract here, the information is going from the pretectal nucleus. It's going to pretectal nucleus. It's also going to the lateral geniculate body, which is about your visual pathway, right? So here we are talking only about the pupillary response. So it can happen that the visual pathway is perfectly fine, but there could be some problem with this pretectal nucleus or something. So pupillary response could have got affected, okay? But visual acuity can still be perfectly fine. But there could be a problem with pupillary response because information goes to both. So we are done with Marcus Gunn pupil. Hope you have understood the causes of Marcus Gunn pupil. That's all for now, guys. Bye-bye. Guys, see, what happens if there is a efferent defect? Let's say there's an efferent pathway defect here. So this one will never constrict, okay? But at least this side, it has a chance of constricting. You see? So this one will never ever constrict. This one, it will never ever constrict. But here, the condition is very different in Marcus Gunn pupil. So in Marcus Gunn pupil, as the afferent has issue, let us say this afferent has issue here. So if there is issue with this afferent, so information will not go to this side, so this will not constrict. Information will not go to this side, so this will also not constrict. Both will not constrict, right? But what will happen if you put light here? See, there's a lesion here. Both did not constrict. But if you have put light on this side and there is no lesion on this side, no problem on this side, so information goes here, this one constricts, and information goes here, and this one also constricts. So both constrict, okay, and both don't constrict when light is put on this eye, which is affected, right? So in this case, when light is here, both eyes will show issue, right? See, what they are saying is normally both the pupils will constrict equally. They will behave equally, okay? But if there is relative afferent pupillary defect in one of the eye, the affected eye will dilate when the light is moved to it, right? It will dilate when the light falls on it from the normal eye.